Thank you, Zoe, for that lovely introduction. So I'm just going to give you a 10 to 15 minute debrief in line with the title of this session about ileal pouch anal anastomosis. So as a friendly reminder, about 10 to 15% of patients with colitis will require surgery. And the most common in the United States is a 3-stage restorative proctocolectomy with ileal pouch anal anastomosis. So to remind you, the first stage is a subtotal colectomy with an ileostomy. After 3 to 6 months, during this time, the patient has time to recover, wean off steroids, get nutritionally optimized. They come back for the second stage. This is the most involved of the stages. It involves a proctectomy, which is removal of the rectum, ileal pouch construction, and then a proximal diverting ileostomy. And the ileostomy here is in place so that the stool is being diverted from the pouch, giving it time to heal. 3 to 6 months later, the patient returns for the third stage, which is ostomy takedown. Now, there's a lot of variations of this stage surgery. Across the board, though, it should be staged. It could either be done in 2 stages or 3 stages. When we've done studies on this here at Sinai and in other centers in the United States, this 3-stage approach is the most optimal because it's associated with less postoperative complications. So there are 2 types of actual anastomoses. So it's called an ileal pouch anal anastomosis, but within that, what you need to know is that there's actually an anastomosis is referring to the pouch to the anal, right? That's the anastomosis. Colloquially, we just call this a J pouch or pouch. So there's 2 types, and these are important because they dictate follow-up and they dictate the different symptoms or syndromes that the patient can develop. There's a stapled anastomosis, which is hands down the most common. This requires that the surgeons leave in place 1 to 2 centimeters of rectum, and this is done so that they can better facilitate an anastomosis between the pouch and that little bit of rectum left in place. And in order to do this, they do this via a stapled anastomosis. So there have been some long-term studies that have shown that a stapled anastomosis is associated with better quality of life, with less seepage and incontinence and pad use. On the flip side, there's the hand-sewn anastomosis. This involves complete removal of the rectum and a mucosectomy such that there's essentially no residual rectum left in place. And here the pouch body is anastomosed directly to the anus. So in theory, this is great because there's no risk of Pouchitis because there's no rectum left in place. And also in theory because you completely reduce or eliminate the risk of cancer that could potentially arise if there's residual rectum left in place. But we do worry in these situations that it's actually harder for these patients who have a history of dysplasia because you can't survey them because there's no cuff left to survey, and that by doing a hand-sewn anastomosis where there's a mucosectomy, removal of the rectal mucosa, you could actually have buried dysplastic cells or that you might not be able to survey. So across the board, staples is the most common that's done, and that's kind of like your standard of care, but in certain patients, there could be a conversation about doing hand-sewn. So what is the pouch and what is pouch anatomy? This is important because as you scope them and as you hear from them, you want to understand what the symptoms are and where they're arising from. So there's a couple of different kind of landmarks. The first is the rectal cuff. So that's here. That's just the little bit of rectum or cuff that's in place. You could see the dentate line here. And then usually when you're inserting the scope, and I scope these patients with a gastroscope, you see this little ridge, and that's the surgical anastomosis. And everything distal to that is the little bit of cuff that's left in place. And again, standard is usually 2 to 3 centimeters. Beyond that, once you enter, you'll see the pouch body. And this is delineated by the owl eyes, right? So to the left is the tip of the J pouch, and that's just the blind limb that's stapled off. And to the right is the pre-pouch ileum, or the afferent limb. And when you go through here, you'll start to see just regular small bowel as you know it from upper endoscopies. I was going to say something else about the scope, but I don't remember now. Somebody remind me later. Now I remember. Okay, so it's important that when you enter the pouch body is that you visualize the staple lines and that they have to be directly related to each other and vertical. So this is important because we're understanding more and more that this is a process that happens in patients long term where their pouch twists. And you might be faced with a consult of a volvulus or a floppy pouch or something like that, where a patient is having obstructive symptoms, but they don't have a clear obstruction on their imaging. And the way that you actually diagnose that is by doing a pouchoscopy and seeing that rather than these staple lines being vertical, they're actually horizontal or they're mismatched. And that's your key that there's a volvulus happening here. So what are...
Sorry, the efferent limb is strictly speaking, something above that anastomotic line?
Yeah.
Like
So exactly. So the
other
efferent
side?
limb is this like very short. It's not best
It's not
portrayed
the whole
in this
thing.
photo. Yes, the efferent limb is essentially right when you go through the anastomosis. There's a small segment that you enter. It looks like small. I mean, it is small bowel, but it's this area that's like right between the anastomosis and the pouch body. And as you scope more and more of these patients, you'll notice that there's a distinct area beyond the like proximal to the anastomosis, but distal to the pouch body. It's usually very short. It's usually like 3 to 5 centimeters, if that. The entire pouch from anus to pouch inlet is about 20 centimeters. And then the proximal diverting ileostomy, that anastomosis site is usually at about 40 centimeters. So you're not putting in too much scope. So the short-term outcomes in the first couple of weeks after surgery, this is a period of adaptation, so the pouch is just kind of used to its new function. So the patients should expect many liquid bowel movements within 24 hours, some urgency. And then as that adaptation period goes on, their frequency decreases to 6 to 8 thick, toothpaste-like bowel movements, and they really shouldn't have any urgency. The long-term outcomes we divide into positive and negative, of course, like everything. Most patients have complete continence, and they have great quality of life. And many would recommend the surgery to their friends and say that it's nowhere as bad as obviously having bad colitis. The negative long-term outcomes include an infertility rate of about 40% in women who've had an open surgery. We expect that this rate has decreased because, of course, in the last decade, all of these surgeries, or the majority of them, have been done laparoscopically. And then, of course, the kind of the most significant negative long-term outcome is pouchitis. And so the manifestations of pouchitis you can see here are not that different than the manifestations of a bad colitis flare, right? There's increased frequency, urgency, cramping, discomfort. When there's cuphitis, there could be bleeding. And we think of pouchitis as a spectrum. So this has evolved. We've understood now that it's not just acute pouchitis and it's not just chronic pouchitis. You can really delineate these disorders with much more granularity. So acute pouchitis occurs in up to 80% of patients, but then about 60% of patients will have at least a recurrence, and then about 20% of these will go on to develop one of these chronic pouchitis phenotypes that we'll get into a little bit more detail. So acute pouchitis is when symptoms occur for less than 4 weeks, and they respond very rapidly. There's 2 to 4 week courses of antibiotics. Chronic antibiotic-dependent pouchitis is very clear in a patient who has recurrent episodes of pouchitis that respond very easily to antibiotics, and sometimes they just need to continue low-dose antibiotics. Chronic antibiotic refractory pouchitis, as the name suggests, is persistent symptoms and real disease despite being on antibiotics. So these are patients that we will talk about considering biologics. And then Crohn's disease, like pouch inflammation, which we're increasingly understanding may just be its completely own phenotype. This is a diagnosis that's made in patients who had a true diagnosis of ulcerative colitis at their time of their colectomy. So what we often do is we go back to their colectomy specimen, we make sure that the pathology was true ulcerative colitis, and we see that about 20% of patients will go on to develop this Crohn's disease-like pouch inflammation. And this is one of 3 different kinds of manifestations: inflammatory, where there's significant pouchitis, but then also pre-pouch ileitis, so inflammation in the pre-pouch ileum that extends greater than 10 centimeters. A fibrostenotic component with stricturing of the pre-pouch ileum or the proximal small bowel, not at the site of anastomoses, and then fistulizing phenotype, where there's fistula that involve the perineum, the pouch, or the proximal small bowel.
Maia?
Yeah.
When you say chronic dependent antibiotics, they might just need low-dose antibiotics long-term. Can you describe the dosing you would do?
Yeah, I'm going to get into it in just 2 more slides, where I have a whole management algorithm for you guys. So for acute pouchitis, we talked about how the cumulative prevalence is up to 80%, but what's a little bit concerning is that we're seeing an increased incidence in the last decade. I mean, in this study from the Denmark cohort showed that there was a 15% absolute and 30% relative increase in the incidence. So how do we manage acute pouchitis? First-line therapy is typically Cipro or Flagyl or a combination of both for 2 weeks. I usually just do Cipro 500 Q12 for 2 weeks. And the key here is that if it's acute pouchitis, they respond fast. Within 48 hours, they have a significant reduction in their stool frequency and their urgency and their discomfort. Now, in patients who have that first relapse, you can consider the same antibiotic that they responded to initially, but a longer course of about 4 weeks. And if they don't have enough of a response, you can add on Flagyl. And then in these patients who have multiple relapses, right, these are the patients that have now gone on to chronic antibiotic-dependent pouchitis, you can consider a couple of different things. You could continue the antibiotic that they responded to most recently, but at the lowest effective dose. So if they had responded to Cipro 500 Q12, you could consider doing 500 daily or even 250 daily. I have some patients who are even on 250 every other day, really trying to get them to that lowest effective dose. You could do the same thing with Flagyl. There is some data that suggests that patients become dependent and then they stop responding, and that's because their microbiome has grown resistant. But if you give them a drug holiday of about 6 weeks where you cycle to another antibiotic, their microbiome turns over and they become they're no longer resistant to that antibiotic. So some people argue that because of that you should cycle antibiotics. I don't empirically cycle. Like I said, I keep people on the lowest effective dose that works for them, and then if they start to lose response, you can consider cycling. Now, how do you manage chronic antibiotic refractory pouchitis or Crohn's disease like pouch inflammation? There's not a lot of data. We'll talk about the only randomized controlled trial that was done in the next slide, but a lot of this data is from retrospective single center cohort studies, a couple of multi-center cohort studies, but there's not enough data to give you a robust recommendation. So what we know is that budesonide can induce a response in about 40 to 60% of patients, and we use it in the same way that we use it in traditional Crohn's and colitis, typically as a bridge to therapy, as a bridge to more lasting maintenance therapy. There's been some data for all of the biologics, the TNFs, ustekinumab, brazinkizumab, vedolizumab, and the response rates are anywhere from 30 to 60%. So they're not, groundbreaking. You're not achieving remission in a lot of patients, and the truth is we don't even really know what remission should be in these patients. We know that we want to improve their quality of life and resolve their symptoms, but are we going for endoscopic remission? Are we going for biomarker remission? Histologic remission? We don't know. So for patients that have chronic antibiotic refractory pouchitis, you could start with budesonide. And there's not a lot of data to support this, but similar to how we manage microscopic colitis with low-dose budesonide, if they have a very robust response and they have contraindications to biologics, or they've been on a lot of these biologics pre-colectomy, you can consider just continuing them on low-dose budesonide. I don't typically do that. I do escalate to a biologic, and I do the same in patients who have Crohn's disease like pouch inflammation. Now, when choosing your biologic, you want to start it early, just as we do in typical IBD, but in patients who've been on a lot of biologics pre-colectomy, you want to consider starting something that they haven't been exposed to. And it's easier said now than before, where before there was only like 3 biologics, and they were all on them before colectomy. But now we have brazinkizumab, we have vedolizumab. Many of these patients weren't exposed to these drugs, and so they're good options.
When you're using budesonide, is it Entocort or Uceris?
I use Entocort. So I use Entocort because it's ileal release. Sometimes you can even have the patient open the capsule and swallow the contents. I use it 9 milligrams for a month, and then I do 6 milligrams for 2 weeks, and then 3 milligrams for 2 weeks. Again, there's no strong evidence to support this, but anecdotally it seems to work. So I mentioned Vedo. So pouchitis in general, there's a paucity of data, and there's a paucity of good data. So this was very exciting because it was the first randomized control double placebo trial in patients with chronic pouchitis. And this was a mix of antibiotic-dependent and antibiotic-refractory pouchitis, so it wasn't pure. And patients at the start all received combination Cipro and Flagyl, and they were allowed to continue for quite a period of time, and they were allowed to go back on it while they were part of the trial. So we saw that there were significant differences in favor of Vedo over placebo in achieving remission and response rates, and using a new endoscopic outcome where it was just reduction of endoscopic ulcers, we saw that there was a significant reduction in those patients who were giving Vedo versus placebo. So this was exciting because it now supports with good data the use of vedolizumab in patients who have chronic pouchitis. So the conclusions, we all know pouchitis is a very common long-term complication. We're seeing increasing incidence not only acute pouchitis but chronic pouchitis, so be ready to recognize it in your patients. It can occur in up to 20%. And as of right now, Vedo is the only biologic that we have good, robust, randomized controlled trial data for, but that doesn't mean it's the only one that you can use. And there's the caveat that many of these patients, even when they go on biologics, you're managing their immune-mediated disease, but they can still have microbiome-mediated disease. That means that they could still get acute pouchitis. So you might still need to continue these patients on antibiotics or require regular use of antibiotics for acute pouchitis episodes. And that's it.
Thank you, Maya.
You're welcome.
I think Dr. Sacker had a quick question. Dr. Sacker, did you have a question?
Is it ever quick?
Your mic is off.
Your mic's off.
Yes, I do have a question, but first just a quick comment that
mucosectomy does not abolish the risk of cancer, and that there are ample reports of cancer even after mucosectomy and hand sewn. It's hard to detect because it can occur under the mucosa, so it's not as common as with staple, but it still occurs. My question is, would you say anything about the sparse literature on fecal microbial transplant for chronic refractory pouchitis?
Right. So that's a really good question and something that we're very interested in at Sinai. So all of the FMT studies that have been done in chronic pouchitis have failed, and a large part of that has been due to poor donor engraftment. So the source of these of the stool in these studies has been from healthy volunteers, right, with intact colons. And what happens is that there's a intrinsic disconnect between the donor stool and the recipient stool, because the pouch in a healthy state doesn't have so much density and diversity of microbes. So you're giving them a lot of healthy stool, which is overwhelming the pouch. So all the studies that have been done, and there's been a couple, and there's been at least 3 RCTs that have been done, have failed. So at Sinai, we are taking a different angle, where we're actually recruiting patients who have a normal, healthy pouch, normal pouchoscopy, no pouchitis within 2 years, and we're collecting their stool, because their stool in a healthy state is more likely to engraft in a patient who has chronic pouchitis. So we actually just recruited and completed collection from our first donor. It's really hard to find somebody who hasn't had pouchitis in 2 years and has a completely normal pouchoscopy. I've screened 500 scopes. But anyway, and we'll give you 10 stool samples. But that's our, so we have funding from Crohn's and Colitis Foundation and Rainin Foundation to do this study. So we'll be recruiting patients who have chronic antibiotic-dependent pouchitis, and giving them stool from a healthy pouch donor.
Lexi raised a great point, but what about using stool from FAP patients?
Yes, so they're also part of the potential donors. The problem with FAP patients is and this is a long conversation, but there were concerns that, are there risks for cancer? Are they is there a microbial component of their risk for cancer? That was something that the FDA was a little bit worried about. They still approved the protocol, but it's also really hard to find a FAP patient.